Good morning, everyone. This is Dr. Eric Bricker, and thank you for watching A Healthcare Z. I apologize for being a little late. Connectivity. So glad. Topic is controversies in denials and prior authorizations. So, as always, let's do an audio video check to start. So, if you can, in the comment section of either LinkedIn or YouTube, let me know if you can see and hear me okay. That would be fantastic. And in the course of the presentation, also know that you can leave questions or comments, and then I will answer them throughout the presentation. That would be super. Now, on to a brief background about myself, because many of you know who I am, but for those who do not, I am Dr. Eric Bricker. Before becoming a physician, I actually was a hospital finance consultant. Then I went on to medical school at the University of Illinois at Chicago. I then went on to an internal medicine residency at Johns Hopkins in Baltimore, and I worked as a hospitalist physician at the Baylor Hospital in Plano, Texas, where I'm located, which is a suburb of Dallas. And I simultaneously started a healthcare navigation firm called Compass Professional Health Services with two other founders, and we grew that healthcare navigation business to over 2,000 employer clients and 1.8 million people that we supported in navigating their health insurance and the U.S. healthcare system. We sold that business to Alight Solutions in 2018, and I started making a bunch of healthcare finance educational videos that is a Healthcare Z on LinkedIn and YouTube. And I am so appreciative of all of you watching. And I'm now also the medical director for Simple Pay Health, which is an alternative health plan. Now, on to denials and prior authorizations. And this gets to the overall of billing and collections in healthcare. And billing and collections in healthcare is incredibly expensive. It is referred to officially as revenue cycle management. So of course, everything has to have some sort of consultant. Probably the consultants I used to work with, they probably came up with that term, right? You can't call it billing and collections. That sounds too boring, right? Revenue cycle management sounds much more sophisticated. Okay, billing and collections is hugely expensive for doctors and hospitals and other healthcare providers like physical therapists. Okay, it cost, one study from the Journal of the American Medical Association for an academic medical center in North Carolina found that this academic medical center spent $99,000 per primary care physician just billing and collecting from insurance companies. It takes gobs and gobs of time and effort. In other words, $1 out of every $7 in revenue that they collected was spent on the actual billing and collection process itself. And that's just for primary care. For other specialties, such as emergency medicine, it can be as high as 25% of revenue is actually spent collecting the revenue. Holy moly. Okay, so this is not due to quote unquote inefficiency and waste on the part of the doctors and hospitals. This is part of the design of the US healthcare system and fee for service third party payment. Okay. The incredibly expensive process of billing and collections in fee for service third party payment is completely by design. It is 100% intentional. Okay, now this has been in the news. ProPublica had an article recently about Cigna denials. In other words, non-payment from health insurance companies, where they have medical directors at various insurance companies, Blue Cross United, Cigna, Aetna. At Cigna, just one single medical director alone denied 60,000 claims in 1 month. And this expose of Cigna by ProPublica found that Cigna denied 300,000 claims over a 2-month period of time, which, when you do the math on it, means that Cigna and their medical directors spent 1.2 seconds per denial. Okay, what's that called? That's called non-human review. Okay, obviously it was a computer that was doing this, not a person. So where are these denials coming from? Okay, these denials are computerized implementation of medical policy. Okay. Now, medical policy, I've done multiple A Healthcare Z videos on this before. Medical policy is the fancy insurance term for you have insurance, but in these various clinical circumstances, we will not pay for care. It is not, quote unquote, medically necessary. Let me give you a specific real example that we had at Compass. I used this before. We had one of our members who had a denial for an ophthalmologist visit where the ophthalmologist used a laser in the office for a particular diagnosis. Now, the insurance company denied payment because they said you can't use the laser to treat that particular diagnosis of the retina. Now, you can use the laser for other diagnoses of the retina, but not for that particular one. And the ophthalmologist was like, "That's ridiculous. That's just like normal. Like the standard of care is to." So there are literally it's over 80 pages of fine print about the variety of clinical situations where your insurance company will not pay. And medical policy varies by insurance companies. So there are some clinical situations where, like, Blue Cross will pay, and for the exact same clinical situation, Aetna will not. And then vice versa. There might be certain clinical situations where Aetna will pay, and then in that exact same clinical situation, Blue Cross will not. So it is the only state in America that says that medical policy has to be established by the physicians and the medical professionals themselves and cannot be established by the insurance company is actually California. So in California, health insurance companies cannot, quote unquote, come up with their own medical policy. It has to be established by professional societies of physicians and clinicians themselves. Okay, in every other state, health insurance company can just make it up. Now, of course, they're like, well, it's clinically rigorous and blah, blah, blah. But the point, it was created by doctors that work for us. But the point is that they then take software to then run through the ICD-10 and CPT codes and identify those clinical situations that per their non-coverage medical policy, and then they just deny coverage and they don't pay. Now, this also non-payment also, this entire video is basically about non-payment. Okay, so another form of non-payment by third-party payers, i.e. insurance companies, is in the form of prior authorizations. So in denials, like in the case of that ophthalmology example I used, there was no prior authorization required. Okay, you have to get beforehand. Okay, it just wasn't covered, period. Okay, now prior authorizations is when for certain services they will be covered. So for like a knee or a hip replacement or for a cardiac stress test, like it'll be covered per the medical policy, but you have to ask permission in advance, and the patient has to meet certain clinical criteria in order for the knee replacement stress test in order to be covered. Okay, so United Healthcare recently, in the past couple of weeks, had an announcement that said that they were going to decrease the number of prior authorizations that they do from 13 million a year to 10 million a year. Okay. Prior authorizations, like, forget about whether you agree or disagree with the clinical criteria for the prior authorizations. They are incredibly burdensome from a time and resources standpoint by the doctors and the nurses that actually have to go through the prior authorization process. Okay, 13 million prior authorizations for only one insurance, United. Okay, if let's just say there is let's an hour to do a prior authorization. Sometimes the health insurance, literally, they will put the physician practice on hold for 4 hours. So to say that it only takes 1 hour is potentially a huge underestimate. Okay, let's just say that's 13 million hours a year in order to obtain prior authorizations. Okay, now there are 2,000 working hours in a year. If you divide 13 million by 2,000, that is 6,500 FTEs that are required. Like their full-time job is just getting prior authorizations from United. And that's just one health insurance company. You've got Blue Cross, you've got Aetna, you've got Cigna, you've got Centene. Okay. You got Molina. Okay. So United's like, okay, look, we're going to decrease our prior authorizations by 23%. We're going to go from 13 million to 10 a year. We at United, we realize the burden that this is for doctors' offices, and we realize that this non-payment through prior authorizations is financially constricting the cash flow of the doctors and hospitals. Okay, that's fine. That's a 23% decrease in the number of prior authorizations. That does not mean it is a 23% decrease in the amount of money that requires prior authorization. That is not 23% of the total claims spend that goes through the prior authorization. And that is because of what is referred to as the Pareto Principle. Now, this is the number one most important slide that I'm going to go over today, because everybody who works in healthcare finance has to have a detailed understanding of the Pareto Principle. In my opinion, it is healthcare finance malpractice if you do not understand the Pareto Principle. So I am going to blow this slide up even more. So it is the 80-20 rule, meaning that you have a chart here where you have let's just say on the x-axis, this is the number of prior authorizations, and they are broken down into 5 tranches of 20% each. So 20% of the prior authorizations, another 20% of the prior authorizations, another. There's 5 tranches, so this adds up to 100% of the prior authorizations. Now, here you have the amount of money per prior authorizations, because some prior authorizations are for procedures that only cost $250, and other prior authorizations are for procedures that cost $250,000. And the point in the 80-20 rule is that 80% of the claim spend or the reimbursement that requires prior authorization is in only 20% of the actual prior authorizations. And that is referred to as the Pareto Principle. Pareto was an Italian economist way back almost in the Middle Ages. It might have been the 17 or the 1800s. Okay, now it stratifies even more. Within that 20%, the top 4% of prior authorizations are actually responsible for 50% of the money that flows through prior authorizations. Now, notice the next 20% is only 12% of the dollars. The next 20% is only 5% of the dollars. The next 20% is only 2% of the dollars. And then the bottom 20% is only 1% of the dollars. That means that potentially, if United decreased their prior authorization count by 20%, they will have only decreased the amount of money impacted by that decrease in prior authorizations by barely more than 1%. So now, is United going to choose this 20%? Is 80% of the money that flows through prior authorization going to be impacted by their change? Probably not. It's probably going to be closer to this end of the money, okay? This same Pareto Principle applies to plan members and costs. The top 20% of plan members drive 80% of the cost for the plan. The top 4% of plan members drive 50% of the costs for the plan. Notice the bottom 20% of plan members only drive 1% of the spend. In other words, the bottom 40% only drive 3% of the spend. Okay, the bottom 60% of a planned population only drives 8% of the total spend. So when you talk about quote unquote engaging the population, it's important. It's super important to know that it's what part of the population are you engaging? Because if you're engaging the bottom 60% of your plan members, then you will have almost zero impact on the plan's cost because that bottom 60% don't generate any claims. So it's not just the quantity of engagement that is important, it is the quality of the engagement. In other words, who are you engaging? That is super important. Okay, Pareto Principle. Okay, it's going to be on a test next week. Get ready. Okay, now, so fine. What are these prior authorizations that have very high dollar amounts associated with them? Okay, one, they are orthopedic surgery and neurosurgeries, i.e. joint replacements like hip and knee replacements, and then spine surgeries for the lumbar spine and the cervical spine, and then scoliosis surgeries. These are surgeries that cost upwards of $50,000 to over $200,000, close to $250,000 for a complex scoliosis surgery. It's for transplant. By far the most common transplant is kidney transplants. Kidney transplants blow heart, liver, and pancreas transplants and lung transplants out of the water, okay? So just know when you talk about transplants, the vast majority of those transplants are kidney transplants, which also cost over $250,000. Next is oncology. So for breast cancer and colon cancer and prostate cancer and lung cancer, those are the big cancers for a health plan, okay? For the surgery, for the chemo, and for the radiation, all of these require prior authorization. Okay, remember that oncology is one of the top 3 diagnostic categories. So orthopedics, oncology, and also then cardiac is the other one. So for pacemakers, ICD, which is an implantable cardiac defibrillator, it's given to people who have congestive heart failure with dilated cardiomyopathy. And then it's also for stress tests and then for echocardiograms, all require prior authorization. So, okay. So in other words, there's gobs and gobs of prior authorizations that are required for other types of services, but they're for much lower dollar amounts. The very high dollar amount areas of prior authorization are in these clinical areas. This is where the money is. Okay, why are denials and prior authorizations so important to a health insurance company? If doctors and hospitals hate prior authorizations so much, and it costs them upwards of 16 to 25% of their revenue to actually do the to actually fight the denials and the prior authorizations to actually get paid, then why in the world during negotiations don't the doctors and hospitals negotiate out the denial and prior authorization process? Be like, look, you negotiate surgeries, like let's just not do prior authorizations. That could be part of the negotiation process. But obviously, denials and prior authorizations are kept in the contracts because they are so the hospital's like, okay, fine, if you're going to put denials and prior authorizations in the contract, then you're going to have to pay me much more per coronary artery bypass graft. You're going to have to pay me much more per spine surgery. Like the hospital could be like, okay, instead of me paying me $250,000 for a scoliosis surgery, then you only have to pay me $150,000, but you got to get rid of the prior authorization. But the insurance company doesn't want to do that, right? Why? Because the denials and the prior authorizations are a very important thermostat to tightly control the medical loss ratio. So remember, the Affordable Care Act said that insurance companies must spend 80 to 85% of all of their premium on claims themselves, and they can then retain 15 to 20%. That 80 to 85% is the medical loss ratio. Okay. So you better believe the health insurance company keep very close tabs on the claims that are being paid out. And they want that medical loss ratio to be as close to the 80 to 85% as humanly possible, and not 87%, not 88%, not 90%, not 92%. Every quarter, for public, especially for publicly traded health insurance companies, they report their medical loss ratio, and the Wall Street analysts look at that number with supreme importance. And if that medical loss ratio number is too high, the stock price is going to get hammered. Okay. So in order to have super tight control, because if you are a CFO at a health insurance company, then you need to make the numbers work. And by golly, you will make the numbers work. And you will make the numbers work by, if you need to adjust up or adjust down denials and authorizations in order to make those numbers work, you will. Here are the medical loss ratios for United going back to Q3 2021, 83%, Q4 2021, 83.7%. Look at that. Only 0.7% different. Q1 2022, the next quarter, 82%. Next quarter, 81.5%. Next quarter, 81.6%. Next quarter, 82.8%. Next quarter, 82.2%. They are remarkably consistent, remarkably, because they use denials and prior authorizations to fine-tune the claim payments that are going out the door. Okay? There is absolutely variability in medical care and claims coming in. The fourth quarter is always higher because that's when people have met their deductibles. And so more claims are submitted. You would expect more claims to be paid out in either the fourth quarter or in the first quarter of the subsequent year. You don't see a change in the medical loss ratio quarter by quarter, because while there are changes in the size and, when people are getting all their surgeries in the fourth quarter, the health insurance companies are intentionally adjusting their payment to smooth out the medical loss ratio through denials and prior authorizations. Okay. Next up, what happened in Q3 and Q4 of 2021? COVID was still raging. Okay. Remember that? COVID didn't start going away until the first quarter of 2022. During COVID, paradoxically, the number of elective surgeries, joint replacements, knee replacements, the amount of cancer surgeries, the amount of cancer treatments, they all went down because the hospitals didn't have the staff and the capacity, or they, for infection control purposes, they could not perform these types of procedures. So in other words, you would expect the medical loss ratio in Q3 and Q4 of 21 and in Q1 of 22 to be lower. But then as COVID lightened up, and then as the knee replacements and the hip replacements and the spine surgeries and the cancer surgeries, as they came back, you would expect the medical loss ratio to go up because more doctors and hospitals were filing more claims to make up for the lack of care that was provided during COVID. Notice what happened to the medical loss ratio. It didn't go up. It didn't go up. 82%, 81%, 81%, 82%. It stayed remarkably flat. Why? Because the insurance carriers have the thermostat of denials and prior authorizations to tightly control, regardless of how many claims are coming in, they can tightly go out through denials and prior authorizations. Okay. Now, this has significant implications for patients. Okay. When any patient goes to the doctor or the hospital, they sign a form that says that the patient is ultimately financially responsible for care. Okay. The doctor or the hospital will bill the insurance company, but if the insurance doesn't pay, then the ultimate financial responsibility lies with the patient. Okay. Medical policy and denials essentially equals non-insurance coverage. It shouldn't be called medical policy. Okay. Medical policy is a completely deceptive term that should not allowed to be used. This is non-coverage. There should be a bright red letters, a non-coverage document that outlines the 80 pages of non-coverage that you had. To call it medical policy is intentionally deceptive. Okay. Next up, prior authorization, again, equals delayed or no insurance. Okay. So people don't have insurance. They kind of have insurance. Okay. Insurance is the transference of risk. Okay. When you have medical insurance, you kinda have the transference of risk. You have 80 pages of non-transference of risk. In my opinion, there needs to be dramatic consumer protections to stop the deceptive practice of medical policy and prior authorizations. Listen, if you want to deny coverage and have non-coverage, that's fine. Have non-coverage for 80 pages of stuff, but it needs to be excruciatingly clear to your plan members who are buying these policies that this is 80 pages of stuff that your insurance will not cover. And that is never explained to people, ever. And that needs to be explained front and center, okay? What's the take-home point for this? Non-payment by carriers results in overall increased healthcare costs because of the revenue cycle management costs just to get paid from third-party payment. Fee-for-service third-party payment is intentionally bad by design, okay? I am not here to say that it is going to change. It's not going to change, okay? When I was a hospital finance consultant in the late 90s, it was exactly the same. It was exactly the same 25 years ago. It is not going to change unless doctors and hospitals do something different themselves. They need to bear risk. They need to get capitated payments. They need to say to fee for service from a third party is for the birds. Forget it. Just pay us up front, and we, the docs and the hospitals, will bear the risk. Docs and hospitals need to own insurance companies like Intermountain does, like UPMC does, like Geisinger does. Forget the insurance company. Start your own insurance company. This is America. It's a free country. Every hospital in America needs to stop playing the revenue cycle management game, and they need to start an insurance company, and they need to engage in direct contracting directly with employers. Okay. The Mercy Hospital in Springfield, Missouri has direct contracts with Walmart and does a ton of business and gets paid incredibly quickly by Walmart. Okay. The Virginia Mason Hospital System in Seattle has direct contracts with major employers, also including Walmart, and gets paid much faster by these payers by using direct contracting. Okay. These hospitals need to change. Okay. I had a friend in college whose father was a vascular surgeon in Connecticut. And I remember him telling me in 1994, talking about the quote unquote recalcitrant third party. And he meant they were recalcitrant in terms of payment. They will always be recalcitrant in terms of payment. That is not going to change. The power to make things better it already exists within hospitals and doctors, and they need to change. Okay. Specifically for patients, when you have a transference of risk back onto you because of denials, there is a solution. That solution is you take your grievance to your employer. Every HR person in America is now going to hate me because of what I'm now saying. Okay. You need to make your employer understand that they have hired a vendor that has then transferred risk to you, the employee. Okay. do not go to the health insurance carrier customer service. You go to HR and you make it incredibly clear that they have hired a vendor that is not paying. Okay. If you are an executive at one of these companies, if you are a highly compensated salesperson or an engineer at one of these companies, you hold tremendous sway within that company. And if you or a family member receive a denial or have a prior authorization, you need to make it excruciatingly clear to HR what is happening to you, because HR has hired that insurance company. HR has the ultimate responsibility for what is happening to you. So, with that, I want to thank you all very much. Again, this is not doom and gloom. This is all of my A Healthcare Z messages are one of empowerment. We have the tools within us today to actually change things, okay? This is not like we don't need to wait for an act of Congress. We have things that each one of us individually can do today to change things, okay? Now, I want to thank you so much for watching. Please connect with me on LinkedIn. Please email me at ericb@ahealthcarez.com if you would like to have a copy of these slides. You can also email me if you would like to receive my daily Monday through Friday A Healthcare Z video email newsletter. You can subscribe to my A Healthcare Z YouTube channel. Believe it or not, our A Healthcare Z YouTube channel has almost 1 million views. Can you believe it? This stuff is so incredibly boring, and it's almost been viewed 1 million times on YouTube. So thank you all so much for your involvement. Now, I am running way over, and so I'm going to answer your questions and comments in writing. Thank you so much for placing them here. So keep your eyes peeled on LinkedIn and YouTube, and I'll reply to your questions and comments there. Thank you all so much. Have a wonderful weekend. Bye now, everybody.